Every once in a while, someone asks me a fair question. Why should I listen to you about running a medical practice? And honestly, you should ask that. There are a lot of people online talking about healthcare, talking about optimization, talking about growth, talking about revenue, but very few of them actually run a clinic. So let me be clear about what this is and what it isn't. This isn't theory. This isn't coaching from the sidelines. And this definitely isn't advice from someone who's never had to make payroll, manage staff turnover, or deal with payer pressure. This is a real medical practice. We see about 200 patients a day. We operate out of 8,000 square feet. We have 24 exam rooms. We run our own imaging, our own clinical lab, our own sterile procedure rooms, which means that when something doesn't work here, you don't just revise the strategy. You feel it immediately, operationally, financially, and clinically. This clinic runs every day. We deal with the same things that you do: staffing shortages, prior authorizations, flat or declining reimbursements, compliance, burnout, patients who need more care than a short visit allows. There's no room here for nice ideas. If something breaks, it costs time, money, or patient trust. Usually all three. And that's why everything I talk about comes from operating inside a live system, not building slides, not selling software, and not guessing. Before I ever shared anything publicly, before I ever helped another practice, before I ever explained a framework or a model, I installed it here first, in this clinic, with our patients, our staff, our risk, our reputation. If it didn't survive real world pressure at scale, it didn't make the cut. And that's especially true for what happens between visits, because that's where most practices quietly struggle. Your team is answering messages, reviewing data, following up on labs, managing adherence, adjusting plans, putting out fires. That work is already happening, but in most practices, it's informal, undocumented, and unpaid. We didn't accept that as just part of medicine. We structured it, we staffed it, we operationalized it, and we made sure that it was compliant and defensible. Not because it sounded good, and not because it had to work on Monday morning with hundreds of patients moving through the building. What you're seeing here isn't a hypothetical. It's not a pilot. It's not a promise. It's the result of years of iteration inside a real, high volume clinic that had to stay profitable, compliant, and functional while delivering good care at scale. So, when I talk about running care between visits, designing internal workflows, building programs that don't burn out your staff, or getting paid fairly for the work your team is already doing, it's not advice from somebody trying to sell you an idea. It's coming from someone who has to live with the outcome every single day. We don't need another expert telling us what should work. You need to hear from someone who's already made it work inside a clinic with real volume, real complexity, and real consequences. That's why you should listen to me. Not because I have a platform, but because I'm still in the arena.